Chapter 14, Department of Health and Human Services, Roger Severino. If the U.S. Department of Health and Human Services, HHS, were a separate country, its approximately $1.6 trillion budget would rank as the world's fifth largest national budget. For good or ill, HHS activities personally impact the lives of more Americans than do those of any other federal agency. Under President Trump, HHS was dedicated to serving all Americans from conception to natural death, including those individuals and families who face economic and social well-being challenges. Under President Biden, the mission has shifted to promoting equity in everything we do for the sake of population sharing a particular characteristic, including race, sexuality, gender identification, ethnicity, and a host of other categories. As a result of HHS's having lost its way, U.S. life expectancy, instead of returning to normal after the COVID-19 pandemic, continued to drop precipitously to levels not seen since 1996, with white populations alone losing 7% of their expected lifespan in just 1 year. Nothing less than America's long-term survival is at stake. Accordingly, HHS must return to serving the health and well-being of all Americans at all stages of life, instead of using social engineering that leaves us sicker, poorer, and more divided. Overview. HHS consists of 11 operating divisions that have varying degrees of practical independence from the Secretary of Health and Human Services, and 15 staff divisions that are directly under the office of the Secretary. This chapter's recommendations are limited to those divisions that most need reform and address, wherever possible, 5 cross-cutting goals. Goal number 1, protecting life, conscience, and bodily integrity. The Secretary should pursue a robust agenda to protect the fundamental right to life, protect conscience rights, and uphold bodily integrity rooted in biological realities, not ideology. From the moment of conception, every human being possesses inherent dignity and worth, and our humanity does not depend on our age, stage of development, race, or abilities. The Secretary must ensure that all HHS programs and activities are rooted in a deep respect for innocent human life from day one until natural death. Abortion and euthanasia are not health care. A robust respect for the sacred rights of conscience, both at HHS and among governments and institutions funded by it, increases choices for patients and program beneficiaries and furthers pluralism and tolerance. The Secretary must protect American civil rights by ensuring that HHS programs and activities follow the letter and spirit of religious freedom and conscience protection laws. Radical actors inside and outside government are promoting harmful identity politics that replaces biological sex with subjective notions of gender identity and bases a person's worth on his or her race, sex, or other identities. This destructive dogma, under the guise of equity, threatens Americans' fundamental liberties as well as the health and well-being of children and adults alike. The next Secretary must ensure that HHS programs protect children's minds and bodies, and that HHS programs respect parents' basic right to direct the upbringing, education, and care of their children. Goal number 2, empowering patient choices and provider autonomy. Basic economics holds that costs tend to decrease and quality and options tend to increase when there is robust and free competition in the provision of goods and services. Healthcare is no exception. Healthcare reform should be patient-centered and market-based, and should empower individuals to control their healthcare-related dollars and decisions. Of course, providers who deliver health care also need the freedom to address the unique needs of their patients. States should be the primary regulators of the medical profession, and the federal government should not restrict providers' ability to discharge their responsibilities or limit their ability to innovate through government pricing controls or irrational Medicare and Medicaid reimbursement schemes. Finally, America's broken insurance system, run largely through confusing provider networks and third party payers, employers, induces overconsumption of health care, limits consumer shopping, and hides true costs from patients. The federal government should focus reform on reducing burdens of regulatory compliance, unleashing innovation in healthcare delivery, ceasing interference in the daily lives of patients and providers, allowing alternative insurance coverage options, and returning control of healthcare dollars to patients making decisions with their providers about their healthcare treatments and services. Goal number 3, promoting stable and flourishing married families. Families comprised of a married mother, father, and their children are the foundation of a well-ordered nation and healthy society. Unfortunately, family policies and programs under President Biden's HHS are fraught with agenda items focusing on LGBTQ plus equity, subsidizing single motherhood, disincentivizing work, and penalizing marriage. These policies should be repealed and replaced by policies that support the formation of stable, married, nuclear families. Working fathers are essential to the well-being and development of their children, but the United States is experiencing a crisis of fatherlessness that is ruining our children's futures. In the overwhelming number of cases, fathers insulate children from physical and sexual abuse, financial difficulty or poverty, incarceration, teen pregnancy, poor educational outcomes, high school failure, and a host of behavioral and psychological problems. By contrast, homes with non-related boyfriends, present, are among the most dangerous place for a child to be. HHS should prioritize married father engagement in its messaging, health, and welfare policies. In the context of current and emerging reproductive technologies, HHS policies should never place the desires of adults over the right of children to be raised by the biological fathers and mothers who conceive them. In cases involving biological parents who are found by a court to be unfit because of abuse or neglect, the process of adoption should be speedy, certain, and supported generously by HHS. Goal number 4, preparing for the next health emergency. The COVID-19 pandemic demonstrated how catastrophic a micromanaging, misinformed, centralized, and politicized federal government can be. Basic human rights, medical choice, and the doctor-patient relationship were trampled without scientific justification and for extended periods of time. Excess deaths, not due to COVID-19, skyrocketed because of forced lockdowns, isolation, vaccine-related mass firings, and colossal disruptions of the economy and daily rhythms of life. The federal government's public health apparatus has lost the public's trust. Before the next national public health emergency, this apparatus must be fundamentally restructured to ensure a transparent, scientifically grounded, and more nimble, efficient, transparent, and targeted response that respects the unique needs and input of patient populations and providers. Every one of the overreaching policies during the pandemic, from lockdowns and school closures to mask and vaccine mandates or passports, received its supposed legal justification from the state of emergency declared and renewed by the HHS Secretary. Tellingly, however, The threshold for what constitutes a public health emergency, how many cases, hospitalizations, deaths, etc., was never defined. For the sake of democratic accountability, we must know with clarity what will trigger the next emergency declaration, and just as important, what will trigger its end. Goal number 5: instituting greater transparency, accountability, and oversight. The next administration should guard against the regulatory capture of our public health agencies by pharmaceutical companies, insurers, hospital conglomerates, and related economic interests that these agencies are meant to regulate. We must erect robust firewalls to mitigate these obvious financial conflicts of interest. All national institutes of health, centers for disease control and prevention, and Food and Drug Administration regulators should be entirely free from private biopharmaceutical funding. In this realm, public-private partnerships is a euphemism for agency capture, a thin veneer for corporatism. Funding for agencies and individual government researchers must come directly from the government with robust congressional oversight. We must shut and lock the revolving door between government and big pharma. Regulators should have a long cooling off period on their contracts. 15 years would not be too long. That prevents them from working for companies they have regulated. Similarly, pharmaceutical company executives should be restricted from moving from industry into positions within regulatory agencies. Finally, HHS should adopt metrics across the agency that can objectively determine the extent to which the agency's policies and programs achieve desired health and welfare outcomes, not agency outputs. What is not measured is not achieved. Centers for Disease Control and Prevention, CDC. COVID and structural reform. COVID-19 exposed the Centers for Disease Control and Prevention, CDC, as perhaps the most incompetent and arrogant agency in the federal government. CDC continually misjudged COVID-19 from its lethality, transmissibility, and origins to treatments. We were told masks were not needed, then they were made mandatory. CDC botched the development of COVID tests when they were needed most. When it was too late, we were told to put our lives on hold for 2 weeks to flatten the curve. That turned into 2 years of interference and restrictions on the smallest details of our lives. Congress should ensure that CDC's legal authorities are clearly defined and limited to prevent a recurrence of any such arbitrary and vacillating exercise of power. The CDC should be split into 2 separate entities housing its 2 distinct functions. On the one hand, the CDC is now responsible for collecting, synthesizing, and publishing epidemiological data from the individual states, a scientific data gathering function. This information is crucial for medical and public health researchers around the country. On the other hand, the CDC is also responsible for making public health recommendations and policies, an inescapably political function. At times, these 2 functions are in tension or clear conflict. In February 2022, for example, it was reported that 2 full years into the pandemic, the agency leading the country's response to the public health emergency has published only a tiny fraction of the data it has collected, much of which could have helped state and local health officials better target their efforts to bring the virus under control. A CDC spokesman said that one of the reasons was fear that the information might be misinterpreted. These distinct functions should be separated into 2 entirely separate agencies with a firewall between them. We need a national epidemiological agency responsible only for publishing data and required by law to publish all of the data gathered from states and other sources. A separate agency should be responsible for public health, with a severely confined ability to make policy recommendations. The CDC can and should make assessments as to the health costs and benefits of health interventions, but it has limited to no capacity to measure the social costs or benefits they may entail. For example, how much risk mitigation is worth the price of shutting down churches on the holiest day of the Christian calendar and far beyond, as happened in 2020? What is the proper balance of lives saved versus souls saved? The CDC has no business making such inherently political and often unconstitutional assessments and should be required by law to stay in its lane. The CDC's initial COVID-19 testing failures were largely the result of that agency's prioritizing its own development and production of tests using its internal staff and facilities. The private sector is much better positioned to tackle the challenges inherent in developing and manufacturing novel products, as illustrated by the relative success of the alternative approach to facilitating the development of COVID-19 vaccines and therapeutics by private companies that was adopted by the Food and Drug Administration, FDA. When it comes to testing, the CDC's role should similarly be to facilitate rather than supplant the efforts of private test developers, academic laboratories, state public health laboratories, and clinical testing providers. When responding to a novel pathogen, the CDC should focus on gathering and disseminating information, including specimens needed for development of positive controls and reference panels, and ensuring that test developers can develop and validate diagnostic tests. These changes will require a shift in priorities and culture at the CDC and throughout HHS more broadly. Most problematically, the CDC presented itself as a kind of super doctor for the entire nation. The CDC is a public health institution, not a medical institution. According to its mission statement, the agency focuses on disease prevention and control, environmental health, and health promotion and health education activities. It is not qualified to offer, and usually does not purport to offer, professional medical opinions applicable to specific patients. From time to time, the CDC offers findings and recommendations that competent medical practitioners often will consider in arriving at a professional medical judgment for a particular patient. In this respect, CDC guidelines are analogous to guidelines from other public health associations or medical societies. They are informative, not prescriptive. By statute or regulation, CDC guidance must be prohibited from taking on a prescriptive character. For example, never again should CDC officials be allowed to say in their official capacity that school children should be masked or vaccinated through a schedule or otherwise, or prohibited from learning in a school building. Such decisions should be left to parents and medical providers. We have learned that when CDC says what people should do, it readily becomes a must, backed by severe punishments, including criminal penalties. CDC should report on the risks and effectiveness of all infectious disease mitigation measures dispassionately and leave the should and must policy calls to politically accountable parties. Conflicts of interest. There was a time when the CDC could not take money from the pharmaceutical industry, but in 1992, the agency discovered a loophole in federal law that allowed it to accept pharma contributions through the nonprofit CDC Foundation. The money started flowing immediately. From 2014 through 2018, the CDC Foundation received $79.6 million from pharmaceutical corporations like Pfizer, Biogen, and Merck. This practice presents a stark conflict of interest that should be banned. Data systems. The COVID-19 pandemic has revealed the disastrous public health consequences of the CDC's failure to follow multiple congressional mandates to modernize its data infrastructure. Current reporting methods are burdensome for frontline medical workers, yet they result only in fragmented data that are not available in real time or usable across systems. Congress should require HHS to prioritize the electronic collection and dissemination of robust, privacy protected data that better leverages existing systems while reducing burdens on clinicians. HHS should also enter into a public private partnership with a data management expert to develop a system that makes critical information available to healthcare workers and policymakers in real time. The CDC operates several programs related to vaccine safety, including the Vaccine Adverse Event Reporting System, VAERS, Vaccine Safety Data Link, VSD, and Clinical Immunization Safety Assessment, CISA project. Those functions and their associated funding should be transferred to the FDA, which is responsible for post-market surveillance and evaluation of all other drugs and biological products. Respect for life and conscience. The CDC should eliminate programs and projects that do not respect human life and conscience rights and that undermine family formation. It should ensure that it is not promoting abortion as health care. It should fund studies into the risks and complications of abortion and ensure that it corrects and does not promote misinformation regarding the comparative health and psychological benefits of childbirth versus the health and psychological risks of intentionally taking a human life through abortion. The CDC oversaw and funded the development and testing of the COVID-19 vaccines with aborted fetal cell lines, insensitive to the consciences of tens of thousands to hundreds of thousands of people who objected to taking a vaccine with such a link to abortion. As evidenced by litigation across the country, it is likely that thousands were fired unjustly because of the exercise of their consciences or faith on this question, which could have been avoided with a modicum of concern for this issue from CDC. There is never any justification for ending a child's life as part of research, and the research benefits from splicing or growing aborted fetal cells and aborted baby body parts can easily be provided by alternative sources. All such research should be prohibited as a matter of law and policy. CDC should update its public messaging about the unsurpassed effectiveness of modern fertility awareness-based methods, FABMs, of family planning, and stop publishing communications that conflate such methods with the long-eclipsed rhythm or calendar methods. CDC should fund studies exploring the evidence-based methods used in cutting-edge fertility awareness. Data collection. The CDC's abortion surveillance and maternity mortality reporting systems are woefully inadequate. CDC abortion data are reported by states on a voluntary basis, and California, Maryland, and New Hampshire do not submit abortion data at all. Accurate and reliable statistical data about abortion, abortion survivors, and abortion-related maternal deaths are essential to timely, reliable public health and policy analysis. Because liberal states have now become sanctuaries for abortion tourism, HHS should use every available tool, including the cutting of funds, to ensure that every state reports exactly how many abortions take place within its borders, at what gestational age of the child, for what reason, the mother's state of residence, and by what method. It should also ensure that statistics are separated by category: spontaneous miscarriage, treatments that incidentally result in the death of a child such as chemotherapy, stillbirths, and induced abortion. In addition, CDC should require monitoring and reporting for complications due to abortion and every instance of children being born alive after an abortion. Moreover, abortion should be clearly defined as only those procedures that intentionally end an unborn child's life. Miscarriage management or standard ectopic pregnancy treatments should never be conflated with abortion. Comparisons between live births and abortion should be tracked across various demographic indicators to assess whether certain populations are targeted by abortion providers and whether better prenatal physical, mental, and social care, improves infant outcomes, and decreases abortion rates, especially among those who are most vulnerable. The Ensuring Accurate and Complete Abortion Data Reporting Act of 2023 would amend Title 19 of the Social Security Act and Public Health Service Act to improve the CDC's abortion reporting mechanisms by requiring states, as a condition of federal Medicaid payments for family planning services, to report streamlined variables in a timely manner. The CDC should immediately end its collection of data on gender identity, which legitimizes the unscientific notion that men can become women and vice versa, and encourages the phenomenon of ever-multiplying subjective identities. Food and Drug Administration, FDA. The FDA's mission includes ensuring the safety and efficacy of drugs, biological products, and medical devices. Federal laws that shield big pharma from competition. Because generics generally cost far less than brand name drugs, consumers begin to save money as soon as a generic product comes on the market. The vast majority are very affordable, with 93% of generic products costing $20 or less. Savings would be even higher under proposals that prevent brand name manufacturers from slowing down or impeding the entrance of generic products into the marketplace. Specifically, the FDA should prohibit pharmaceutical companies from purposely sitting on their legally available right to be the first to sell generic versions of their drugs. Additionally, Congress should create legal remedies for generic companies to obtain samples of brand name products for their generic development efforts, and should prohibit meritless citizen petitions submitted by manufacturers to delay approval of a generic competitor. Approval process for laboratory-developed or modified medical tests. Learning from the failed early COVID-19 testing experience, Congress and the FDA should focus on reforming laws and regulations governing medical tests, especially with respect to laboratory-developed tests. Commercial tests are developed with the intention of being widely marketed, distributed, and used, while laboratory-developed tests are created with the intention of being used solely within one laboratory. A test developed by a lab in accordance with the protocols developed by another lab, non-commercial sharing, currently constitutes a new laboratory-developed test because the lab in which it will be used is different from the initial developing lab. To encourage interlaboratory collaboration and discourage duplicative test creation and associated regulatory and logistical burdens, the FDA should introduce mechanisms through which laboratory-developed tests can easily be shared with other laboratories without the current regulatory burdens. The laboratory-developed tests category currently encompasses a range of possible tests, many of which would be characterized more appropriately as laboratory-modified tests, because they are not truly novel tests, but rather modified versions of existing tests. To avoid stifling innovation and access to medical care, The applicable statutes and regulations should be revised to facilitate greater access to such modified tests. Finally, the FDA has long held that it has regulatory authority over such tests, while others have argued that they should be considered clinical services regulated by the Centers for Medicare and Medicaid Services, CMS. The FDA currently has regulatory authority over in vitro diagnostics, and under the Clinical Laboratory Improvement Amendments, CLIA, the CMS ensures that labs meet analytical validity standards for test methods. Congress, the FDA, and the CMS need to clarify and disentangle overlapping authorities over tests to eliminate regulatory confusion. Drug shortages. The very thin profit margins and the regulatory burdens associated with generic drug manufacturing discourage inventory and capacity investments by manufacturers and contribute to drug shortages. HHS and the FDA should encourage more dependable generic drug manufacturing. The FDA should expand its current pass-fail approach to drug facility inspections into a graded system that recognizes manufacturers that exceed minimum standards by investing in improving production reliability. The FDA should also add facility codes to drug packaging and construct a searchable database that cross-references product codes and facility codes. That would enable wholesalers and pharmacy benefit managers to identify and preference drugs manufactured at more reliable facilities, thus encouraging generic drug manufacturers to compete on reliability as well as on price. For its part, HHS should exempt multi-source generic drugs from requirements to pay rebates to Medicaid and other federally funded health programs, as those provisions penalize new investments in expanding manufacturing capacity when supply is unable to meet demand. Additionally, FDA and NIH should promote efficacy trials of new applications for generic drugs, which might include NIH funding such trials or conducting its own. Abortion pills. Abortion pills pose the single greatest threat to unborn children in a post-Roe world. The rate of chemical abortion in the U.S. has increased by more than 150% in the past decade. More than half of annual abortions in the U.S. are chemical rather than surgical. The abortion pill regimen is typically a two-part process. The first pill, mifepristone, causes the death of the unborn child by cutting off the hormone progesterone, which is required to sustain a pregnancy. The second pill, misoprostol, causes contractions to induce a delivery of the dead child and uterine contents, usually into a toilet at home. The abortion pill regimen is currently approved for up to 70 days, 10 weeks, into pregnancy, and before Biden was subject to a heightened safety restriction called a Risk Evaluation and Mitigation Strategy, REMS, that requires an in-person visit with a physician who can check for dangerous contraindications such as ectopic pregnancies and can advise the mother seeking an abortion of the risks of chemical abortion, including hemorrhaging, and what to do in such circumstances. Chemical abortion has been found to have a complication rate 4 times higher than that of surgical abortion. Since its approval more than 20 years ago, mifepristone has been associated with 26 deaths of pregnant mothers, over 1,000 hospitalizations, and thousands more adverse events. But that number does not account for all complications. Of course, this does not count the hundreds of thousands to millions of babies whose lives have been unjustly taken through chemical abortion. FDA should therefore reverse its approval of chemical abortion drugs because the politicized approval process was illegal from the start. The FDA failed to abide by its legal obligations to protect the health, safety, and welfare of girls and women. It never studied the safety of the drugs under the labeled conditions of use, ignored the potential impacts of the hormone-blocking regimen on the developing bodies of adolescent girls, disregarded the substantial evidence that chemical abortion drugs cause more complications than surgical abortions, and eliminated necessary safeguards for pregnant girls and women who undergo this dangerous drug regimen. Furthermore, at no point in the past 2 decades has the FDA ever acknowledged or addressed federal laws that prohibit the distribution of abortion drugs by postal mail. To the contrary, the FDA has permitted and actively encouraged such activity. Now that the Supreme Court has acknowledged that the Constitution contains no right to an abortion, the FDA is ethically and legally obliged to revisit and withdraw its initial approval, which was premised on pregnancy being an illness and abortion being therapeutically effective at treating this illness. The FDA is statutorily charged with guaranteeing the safety and efficacy of drugs, and therefore should withdraw this drug that is proven to be dangerous to women and, by definition, fatally unsafe for unborn children. As an interim step, the FDA should immediately restore the REMS by removing the in-person dispensing requirement to eliminate dangerous teleabortion and abortion by mail distribution. Mail order abortions. Allowing mail order abortions is a gift to the abortion industry that allows it to expand far beyond brick and mortar clinics and into pro-life states that are trying to protect women, girls, and unborn children from abortion. The FDA should therefore reinstate earlier safety protocols for mifeprex that were mostly eliminated in 2016 and apply these protocols to any generic version of mifepristone. A bare minimum policy of limiting abortion pills to the pre-2016 policy of 49 days gestation, returning to the pre-2021 in-person dispensing requirement, and returning to requiring prescribers to report all serious adverse events, not just deaths, to the drug sponsor would increase women's health and safety. Address weaknesses in the current FAERS, FDA Adverse Events Reporting System. The administration and policymakers should ensure that health care workers, particularly those in hospitals and emergency rooms, report abortion pill complications. Women who experience complications from abortion pills typically go to an emergency room, not to the abortion pill prescriber, so putting the onus of reporting on the prescriber, who typically has no idea that a complication has occurred, means that the FAERS is seriously undercounting adverse events. Submitting an adverse event to the database should be a quick and efficient process for busy healthcare practitioners. Currently, providers report that the process is difficult and convoluted. Implement a policy of transparency about inspections of the abortion pill sponsors, Danco and GenBio Pro, as well as facilities that manufacture the pills. The FDA should respond to congressional requests and Freedom of Information Act (FOIA) requests about inspections, compliance, and post-marketing safety in a timely manner. Stop promoting or approving mail-order abortions in violation of long-standing federal laws that prohibit the mailing and interstate carriage of abortion drugs. Vaccine importation. Thousands of Americans of faith and conscience wish to receive various childhood vaccinations for themselves and their families, but are not allowed to receive vaccines that are derived through or tested on aborted fetal cells. For example, the chickenpox, hepatitis, and MMR vaccines in the U.S. are all linked to abortion in this way. There are ethically derived alternatives abroad that have been used safely there for decades, but the FDA makes it exceedingly difficult for Americans to import them. In January 2021, the HHS Office for Civil Rights, OCR, and the FDA jointly announced that HHS was required by the Religious Freedom Restoration Act, RFRA, to allow bulk importation by doctors of certain Japanese-made vaccines to accommodate religious needs of patients, but the Biden FDA unlawfully revoked this waiver. The FDA should restore the waiver to comply with RFRA and for the obvious public health benefits of increased childhood vaccination by families seeking ethically derived alternatives. To avoid future moral coercion of the sort experienced with the COVID-19 vaccines, the FDA and NIH should require the development of drugs and biologics that are free from moral taint and switch to cell lines that are not derived from aborted fetal cell lines or aborted baby body parts. Conflicts of interest. A 2018 report in Science found that more than two-thirds of FDA reviewers later ended up at the same companies whose products they had been reviewing while they were working for the government. This revolving door is one mechanism by which pharmaceutical companies capture the agencies that regulate them. The FDA should impose a lengthy cooling-off period for reviewers, preventing them from working for companies they regulated. In 1997, the FDA relaxed regulations to permit broadcast drug advertisements, after which Big Pharma began routine direct-to-consumer advertising, making the United States and New Zealand the only countries where such practices are legal. Following the 1997 changes, pharma became the largest advertiser for all major media organizations. This buys considerable influence in the newsroom, whether media companies acknowledge this or not, and distorts independent reporting on public health issues. The FDA or Congress should regulate where and how paid advertising is used by pharmaceutical companies more stringently, especially on media outlets. National Institutes of Health, NIH. The National Institutes of Health, NIH, is the world's largest biomedical research agency and is made up of 27 different components called institutes and centers. Despite its popular image as a benign science agency, NIH was responsible for paying for research in aborted baby body parts, human-animal chimera experiments, and gain-of-function viral research that may have been responsible for COVID-19. Bioethics reform. Research using fetal tissue obtained from elective abortions is immoral and obsolete. Research using human embryonic stem cells also involves the destruction of human life and should not be subsidized with taxpayer dollars. Good science and life-affirming, ethical research are not mutually exclusive. In fact, ethically derived sources such as discarded surgical tissue and adult stem cells made pluripotent, not tissue obtained from elective abortions, have contributed the most successful treatments for a variety of ailments. Congress authorized HHS to choose not to fund extramural abortion-derived fetal tissue research that fails Ethics Advisory Board review, and in 2019, the Trump administration's HHS chose that course. Subsequently, however, the Biden administration restored unrestricted funding of abortion-derived fetal tissue research. HHS should promptly restore the Ethics Advisory Committee to oversee abortion-derived fetal tissue research, and Congress should prohibit such research altogether. End intramural research projects using tissue from aborted children within the NIH, which should end its human embryonic stem cell registry. Aggressively implement a plan to pursue and fund ethical alternative methods of research in order to ensure that abortion and embryo-destructive related research, cell lines, and other testing methods become both fully obsolete and ethically unthinkable. In addition, the administration should reconvene a new National Council on Bioethics, NCB, to discuss new and emerging areas of ethical concern, to assess whether the ends justify the means when it comes to the promise of therapies and cures, and to establish what limiting principles should guide research and health policy. Because the male female dyad is essential to human nature, and because every child has a right to a mother and father, three-parent embryo creation and human cloning research should be banned. A new NCB should convene leading experts to examine these issues and provide policy recommendations for the new frontier of bioethical questions that our country will have to address in the coming years. Finally, HHS should create and promote a research agenda that supports pro-life policies and explores the harms, both mental and physical, that abortion has wrought on women and girls. Conflicts of interest. NIH maintains inappropriate industry ties that create serious conflicts of interest. In 2018, it was revealed that a $100 million NIH study on the benefits of moderate drinking was funded by the beer and liquor industry. More recently, the National Institute of Allergy and Infectious Diseases, NIAID, Anthony Fauci's division of the NIH, owns half of the patent for the Moderna COVID-19 vaccine, among thousands of other pharma patents. Rather than providing grants to university-based investigators to run the clinical trials on their own Moderna vaccine, the NIH conducted this research internally, a clear conflict of interest. The NIAID will earn millions from this vaccine's revenue, with several NIH employees and their heirs personally receiving up to $150,000 annually from Moderna vaccine sales. In May 2022, documents obtained pursuant to a FOIA request revealed that NIH Director Francis Collins, NAD Director Anthony Fauci, and Fauci's Deputy Director, Clifford Lane, all received royalties from pharmaceutical companies between 2009 and 2014. Nonprofit watchdog Open the Books estimates that from 2010 to 2020, third parties paid more than $350 million in royalties to NIH and its scientists, who are credited as co-inventors. Most problematically, in the years when they received payments, Collins, Fauci, and Lane were NIH administrators, not researchers, with no plausible claim to be scientific co-discoverers. Most of the world's other advanced science countries have stricter prohibitions on such conflicts, which helps to explain why the most significant studies on COVID treatments, on natural immunity, and on vaccine efficacy have come mostly from outside the U.S. Funding for scientific research should not be controlled by a small group of highly paid and unaccountable insiders at the NIH, many of whom stay in power for decades. The NIH monopoly on directing research should be broken. Term limits should be imposed on top career leaders at the NIH, and Congress should consider block granting NIH's grants budget to states to fund their own scientific research. Nothing in this system would prevent several states from partnering to co-fund large research projects that require greater resources or impact larger regions. Likewise, the establishment of funding for scientific research at the state level does not preclude more modest federal funding through the National Institutes of Health. The two models are not mutually exclusive. The CDC and NIH foundations, whose boards are populated with pharmaceutical company executives, need to be decommissioned. Private donations to these foundations, a majority of them from pharmaceutical companies, should not be permitted to influence government decisions about research funding or public health policy. Woke policies. Under Francis Collins, NIH became so focused on the Me Too movement that it refused to sponsor scientific conferences unless there were a certain number of women panelists, which violates federal civil rights law against sex discrimination. This quota practice should be ended, and the NIH Office of Equity, Diversity, and Inclusion, which pushes such unlawful actions, should be abolished. NIH has been at the forefront in pushing junk gender science. Instead, it should fund studies into the short-term and long-term negative effects of cross-sex interventions, including affirmation, puberty blockers, cross-sex hormones and surgeries, and the likelihood of desistance if young people are given counseling that does not include medical or social interventions. Centers for Medicare and Medicaid Services, CMS. With the goal of being a societal safety net, Medicare and Medicaid touch more American lives than does any other federal program. While they help many, they operate as runaway entitlements that stifle medical innovation, encourage fraud, and impede cost containment, in addition to which their fiscal future is in peril. Both programs should be managed so that the individuals enrolled are empowered to make decisions for themselves and have quality options with affordable prices driven by competition and innovation. Providers who participate should retain or have restored the freedom to practice medicine and take care of their patients according to their patients' unique needs. Medicare. Medicare should be reformed according to 4 goals and principles. Increase Medicare beneficiaries' control of their health care. Patients are best positioned to determine the value of healthcare services, working with their healthcare providers. They also benefit from increased choice of doctors, hospitals, and insurance plans. Access to reliable information with respect to physicians, hospitals, and insurers is therefore essential. Reduce regulatory burdens on doctors. Doctors must be free to focus on treating patients first, not entering codes on computers, and should not be tempted to change their medical judgment based on arbitrary or illogical reimbursement incentives. Ensure sustainability and value for beneficiaries and taxpayers. Prices are best for patients when determined by economic value rather than political power, and when they are known in advance of the receipt of services. Government's use of non-market-based methods to determine reimbursement leads to overspending on low-value services and products and underpayment for high-value services and products, stifles beneficial innovation, and because of Medicare's size, distorts payments throughout the healthcare system. Intermediate entities that can manage financial risk and ensure quality of care are important in transitioning to value-based care within the Medicare program. Reduce waste, fraud, and abuse, including through the use of artificial intelligence for their detection. Regulatory reforms. Medicare regulations restrict choice of coverage and care. The next administration should reintroduce and restore regulations and demonstrations from the Trump administration that were withdrawn, weakened, or never finalized by the Biden administration, including the Medicare Coverage of Innovative Technologies, MCIT rule, the Risk Adjustment Data Validation, RADV rule, the Medicare Advantage Qualifying Payment Arrangement, Incentive Mackey Demonstration, and the Global and Professional Direct Contracting, GPDC, rebranded as the Accountable Care Organization. Realizing Equity, Access, and Community Health, or ACO REACH, model. Additionally, regulations should advance site neutrality by eliminating the inpatient-only list and expanding the ambulatory surgical center covered procedures list. Medicare generally pays more for inpatient hospital procedures and less for the same procedures performed in an outpatient setting. Whether a medical service is delivered in a physician's office, a clinic, or a hospital setting, the Medicare payment for that service should be the same. CMS should expand the application of site-neutral payment options to more settings. Such a policy would level the playing field among providers and remove the financial disabilities for medical professionals who would compete with hospital systems. Finally, HHS needs to restore and enhance conscience protection regulations that allow medical practitioners to participate in federal health care programs without being compelled to provide sex changes or similar services. Legislative proposals: remove restrictions on physician-owned hospitals. The Affordable Care Act, ACA, imposed restrictions prohibiting Medicare from reimbursing physician-owned and specialty hospitals. The current restrictions do little more than serve the special interests of large hospital systems and undercut consumer choice of high-quality specialty care. These restrictions should be removed so that physician-owned hospitals can compete with other hospitals in serving Medicare patients. Encourage more direct competition between Medicare Advantage and private plans. Medicare Advantage, MA, a system of competing private health plans, is the major alternative to traditional Medicare for America's large and growing cohort of seniors. The program provides beneficiaries with a wide range of competitive health plan choices, a richer set of benefits than traditional Medicare provides, and at a reasonable cost. Equally as important, the MA program has been registering consistently high marks for superior performance in delivering high-quality care. Critical reforms are still needed to strengthen and improve the program for the future. Specifically, 1. Make Medicare Advantage the default enrollment option. 2. Give beneficiaries direct control of how they spend Medicare dollars. 3. Remove burdensome policies that micromanage MA plans. 4. Replace the complex formula-based payment model with a competitive bidding model. 5. Reconfigure the current risk adjustment model. 6. Remove restrictions on key benefits and services, including those related to prescription drugs, hospice care, and medical savings account plans. Legacy Medicare reform. Legislation reforming. Legacy non-MA. Medicare should base payments on the health status of the patient or intensity of the service, rather than where the patient happens to receive that service. Replace the bureaucrat-driven fee-for-service system with value-based payments to empower patients to find the care that best serves their needs. Codify price transparency regulations. Restructure 340B drug subsidies toward beneficiaries rather than hospitals. Repeal harmful health policies enacted under the Obama and Biden administrations, such as the Medicare Shared Savings Program and Inflation Reduction Act. Medicare Part D reform. The Inflation Reduction Act, IRA, created a drug price negotiation program in Medicare that replaced the existing private sector negotiations in Part D with government price controls for prescription drugs. These government price controls will limit access to medications and reduce patient access to new medication. This negotiation program should be repealed, and reforms in Part D that will have meaningful impact for seniors should be pursued. Other reforms should include eliminating the coverage gap in Part D, reducing the government share in the catastrophic tier, and requiring manufacturers to bear a larger share. Until the IRA is repealed, an administration that is required to implement it must do so in a way that is prudent with its authority, minimizing the harmful effects of the law's policies and avoiding even worse unintended consequences. Medicaid. Over the past 45 years, Medicaid and the health safety net have evolved into a cumbersome, complicated, and unaffordable burden on nearly every state. The program is failing some of the most vulnerable patients, is a prime target for waste, fraud, and abuse, and is consuming more of state and federal budgets. The dramatic increase in Medicaid expenditures is due in large part to the ACA, Obamacare, which mandates that states must expand their Medicaid eligibility standards to include all individuals at or below 138% of the federal poverty level, FPL, and the public health emergency, which has prohibited states from performing basic eligibility reviews. The overlap of available benefits among the various health agencies has led to a complex, confusing system that is nearly impossible to navigate, even for recipients. Recipients are often faced with a welfare cliff of benefit losses as they earn above a certain amount, which is contrary to the fundamental purpose of empowering individuals to achieve economic independence. Benefits increasingly involve non-medical services such as air conditioning and housing, many of which are already handled by departments other than HHS. Improper payments within Medicaid are higher than those of any other federal program. These payments are evidence of the inappropriateness of Medicaid's expansion, which, stemming largely from public health emergency maintenance of effort, MOE requirements, and the Affordable Care Act, has crowded out the primary targets of these programs, those who are most in need. True healthcare reform cannot be accomplished in a bureaucratic silo or only through Medicaid and health safety net programs. Reform of the tax code is also essential to genuine, effective reform of our healthcare system. All components of the healthcare system should be part of the reform efforts, and it is imperative that the system be modified to assist states with their current programs. Therefore, the next administration should reform financing, allow states to have a more flexible, accountable, predictable, transparent, and efficient financing mechanism to deliver medical services. This system should include a more balanced or blended match rate, block grants, aggregate caps, or per capita caps. Any financial system should be designed to encourage and incentivize innovation and the efficient delivery of healthcare services. Federal and state financial participation in the Medicaid program should be rational, predictable, and reasonable. It should also incentivize states to save money and improve the quality of health care. Direct dollars to beneficiaries more effectively and responsibly. The current funding structure for the Medicaid program rewards expansions, lacks transparency, and promotes financing gimmicks. CMS should 1. End state financing loopholes. 2. Reform payments to hospitals for uncompensated care. 3. Replace the enhanced match rate with a fairer and more rational match rate. 4. Restructure basic financing and put the program on a more fiscally predictable budget, which should include reform of disproportionate share hospital payments to hospitals. Strengthen program integrity. Make program integrity a top priority and the responsibility of the states. To protect the taxpayer's investment. 1. Incentivize states. An enhanced contingency fee should be paid to states that successfully increase their efforts to decrease waste, fraud, and abuse. The current system's IT development 90-10 matching rate should be allowed for improvements in states' current fraud and abuse and eligibility systems. Innovative programs that show a positive return on investment for both the state and federal governments should be allowed without the onerous waiver process. 2. Improve Medicaid eligibility standards to protect those in need. As Medicaid enrollment continues to climb, it is imperative that there are appropriate and accurate eligibility standards to ensure that the program remains focused on serving those who are in need. To this end, CMS should hold states accountable for improper eligibility determinations, require more robust eligibility determinations, strengthen asset test determinations within Medicaid. 3. Conduct oversight and reform of managed care. Incentivize personal responsibility. CMS should allow states to ensure that Medicaid recipients have a stake in their personal health care and a say in decisions related to the Medicaid program. Personal responsibility and consumer choice for Medicaid recipients must go together as standard components of the safety net, especially for able-bodied recipients. Medicaid recipients, like the rest of Americans, should be given both the freedom to choose their health plans and the responsibility to contribute to their health care costs at a level that is appropriate to protect the taxpayer. Add work requirements and match Medicaid benefits to beneficiary needs. Because Medicaid serves a broad and diverse group of individuals, it should be flexible enough to accommodate different designs for different groups. For example, CMS should launch a robust personal option to allow families to use Medicaid dollars to secure coverage outside of the Medicaid program. CMS should also 1. Clarify that states have the ability to adopt work incentives for able-bodied individuals, similar to what is required in other welfare programs, and the ability to broaden the application of targeted premiums and cost sharing to higher income enrollees. 2. Add targeted time limits or lifetime caps on benefits to disincentivize permanent dependence. Allow private health insurance. Congress should allow states the option of contributing to a private insurance benefit for all members of the family in a flexible account that rewards healthy behaviors. This reform should also allow catastrophic coverage combined with an account similar to a health savings account, HSA, for the direct purchase of health care and payment of cost sharing for most of the population. Increase flexible benefit redesign without waivers. CMS should add flexibility to eliminate obsolete mandatory and optional benefit requirements, and, for able-bodied recipients, eliminate benefit mandates that exceed those in the private market. This should include flexibility to redesign eligibility, financing, and service delivery of long-term care to serve the most vulnerable and truly needy, and eliminate middle-income to upper-income Medicaid recipients. Eliminate current waiver and state plan processes. CMS should allow providers to make payment reforms without cumbersome waivers or state plan amendment processes where possible. More broadly, the federal government's role should be oversight on broad indicators like cost effectiveness and health measures like quality, health improvement, and wellness should give the balance of responsibility for Medicaid program management to states. This reform would include adding Section 1115 waiver requirements in some cases, such as imposing work requirements for able-bodied adults, while rescinding requirements in others, such as non-health care benefits and services related to climate change. Affordable Care Act and private health insurance. Remove barriers to direct primary care. Direct primary care, DPC, is an innovative healthcare delivery model in which doctors contract directly with patients for their care on a subscription basis, regardless of how or where the care is provided. The DPC model is improving patient access, driving higher quality and lower cost, and strengthening the doctor patient relationship. DPC has faced many challenges from government policymakers, including overly exuberant attempts at regulation and misclassification. Changes should clarify that DPC's fixed fee for care does not constitute insurance in the context of health savings accounts. Revisit the No Surprises Act on surprise medical billing. The No Surprises Act protected consumers against balance bills, but it also established a deeply flawed system for resolving payment disputes between insurers and providers. This government-mandated dispute resolution process has sown confusion among arbiters and regulators as judges have sought to ascertain its meaning. The No Surprises Act should scrap the dispute resolution process in favor of a truth in advertising approach that will protect consumers and free doctors, insurers, and arbiters from confused and conflicting standards for resolving disputes that the disputing parties can best resolve themselves. Facilitate the development of shared savings and reference pricing plan options. Under traditional insurance, patients who choose lower cost care do not benefit financially from that choice. Barriers to rewarding patients for cost-saving decisions should be removed. CMS should ensure that shared savings and reference pricing models that reward consumers are permitted. Separate the subsidized ACA exchange market from the non-subsidized insurance market. The Affordable Care Act has made insurance more expensive and less competitive, and the ACA subsidy scheme simply masks these impacts. To make health insurance coverage more affordable for those who are without government subsidies, CMS should develop a plan to separate the non-subsidized insurance market from the subsidized market, giving the non-subsidized market regulatory relief from the costly ACA regulatory mandates. Strengthen hospital price transparency. In 2020, CMS completed its rule to require hospitals to post the prices of common hospital procedures. Future updates of these rules should focus on including quality measures. Combined with the shared savings models and other consumer tools, these efforts could deliver considerable savings for consumers. Center for Consumer Information and Insurance Oversight, CCIIO. CMS also plays an outsized role in overseeing the Obamacare exchanges, including managing healthcare.gov through the Center for Consumer Information and Insurance Oversight, CCIIO. While Obamacare limits plan options, CCIIO has been overly prescriptive in dictating what benefits and types of health plans may participate in the exchanges, thereby actually stifling market innovation and driving up costs. Congress should build on the Trump administration's efforts to expand choices for small businesses and workers, both in and out of the exchanges, by codifying an expansion of association health plans, short-term health plans, and health reimbursement arrangements, including individual coverage HRAs. CCIIO should also work with the Treasury Department and the Office of Management and Budget, OMB, to give consumers more flexibility with their healthcare dollars through expanded access to health savings accounts. Emergency preparedness. Expand the scope of practice of low complexity and moderate complexity clinical laboratories. During the COVID-19 pandemic, allowing laboratories greater regulatory flexibility regarding CLIA requirements increased access to testing. However, the need for regulatory flexibility is not limited to emergency situations. Ongoing innovations in medical care will continue to drive demand for clinical testing and new tests. One way that increasing demand for other medical services has been accommodated is by revising restrictions on scope of practice to enable providers to practice at the so-called top of their license. CMS should similarly revise CLIA rules regarding scope of practice for clinical laboratories and testing personnel. Create CLIA certification equivalent pathways for non-clinical laboratories and researchers. The COVID-19 pandemic revealed that the U.S. needs to leverage the expertise of non-clinical laboratories and researchers in order to bolster clinical testing capacity. To accomplish this, CMS should create pathways for granting non-clinical laboratories and their testing personnel CLIA certification equivalency. Non-clinical researchers already demonstrate their technical expertise through online training and certification programs. CMS should build on that existing framework so that those laboratories and personnel can similarly demonstrate their clinical testing capabilities.